Am I audible?
Yes, loud and clear.
Am I audible?
Yes, you are.
Am I visible?
You are visible also. This is the common dialogue which we hear after COVID. Am I audible? Am I visible? Are my slides visible or am I audible?
करना पड़ता है क्योंकि कभी-कभी नहीं होता है ना, मैं इधर बोलते रहूं उधर पता चला स्लाइड्स आए नहीं।
मैं मजाक कर रहा हूँ यार। बिल्कुल करना पड़ता है।
Hello.
Hello and good evening. Going ahead with our format of in conversation with an expert, we have our own true expert who has taught all of us lamellar corneal transplant and many more things in life. It's my pleasure to introduce Dr. Rajesh Fogla to you. Of course, he doesn't need any introduction. It would be a crime to introduce Dr. Rajesh Fogla. But I was telling Rajesh that it's very rare where we get to hear him for longer time, because many times whenever we listen to him, we wish that the time doesn't stop, or the timer doesn't stop rather, and we keep getting more and more pearls. For whenever you spend time with him, even 10 minutes, you'll get some pearl, that something different which you never thought of. He's truly a legend in terms of whether we call about corneal surgeries or whether we talk about how to conduct professional and personal life. In fact, I remember way back 20 years back, I was when I was in LVP, Dr. Santosh, at that time Rajesh had joined Apollo, and we were talking, something was in discussion. I was talking to Dr. Santosh on our, and he said one thing that, Himansh, if you want to learn how to conduct your career or how to lead a cornea practice and how to put yourself in the cornea field, you should look at this gentleman. His name is Dr. Rajesh Fogla. I said, of course I know him. I said, just see how he conducts himself. And that's something which I really found unusual. from the mouth of Santosh Honavar, who does not give too much of credit to a cornea person, and that to somebody who is not even working with him. So all of us, we know that Rajesh has so many different area of interest, and in this thing, what we try to do is we will try to talk about questions what you all have sent across, and along with that, he's going to show us what he currently is doing in his surgical practice, his technique of initially DMEK, and anything whatever later on he shows us. I've already passed on question to him in advance, and so he's trying to include all those answers during his talk. What is remaining, me and my partner in crime, Dr. Bela, we will try to elicit it from him. Mm, if I like to call up, Bela is right here. So Bela, would you like to say something before we start?
I have, absolutely. I have a lot of firsts with Dr. Fogla in the sense that my first phacoemulsification, he was teaching there, me, my first phacoemulsification, and then my first lamellar keratoplasty also he was teaching me. So my career of cornea actually, if you see, started with him, and it is my pleasure to be actually talking to him now, cornea as well as beyond cornea, because that is what interests us much more now, as we are probably reaching those stages when we have to look beyond cornea as well. So if your interest is DMEK and DSEK, my lookout is to pester him for the beyond cornea interests of his that he's developed.
Perfect. Welcome, Rajesh. And we started, before we start, we just want to know briefly about your childhood. Where did you grow up, and how did you end up in Shankar Netralaya? What was your journey?
Well, I never wanted to be an ophthalmologist.
Okay.
Back when I was doing my MBBS, I always, when I went through medicine and surgery, medicine was like a trial and error, because you used to see that everybody is making a diagnosis and sometimes you're not definitely. And whereas surgery, you open and you see, mostly those days it was laparatomy. So it was a direct observation, and so I knew that I was more interested in surgery, and I thought I'll go in for to become a plastic surgeon. But while I started doing my internship and I went through ophthalmology, one thing which was very gratifying was that those were the days of total cataract. So you have the patient the previous day not being able to see anything, and somebody does a ICC or an ECC for him, and the very next day we used to go and do the dressing for the eye, but the patient used to express the gratitude to you, thanking you for making him see. So that was something which I felt was very, very rewarding, in the sense that you felt that you are making a huge difference to somebody's life. And also looking at the eye under the microscope in magnification and the microsurgery, it kind of, evoked interest. And then I thought that, yes, this is what I should follow. And the person who inspired me was Dr. Harsha Bhattacharya, who was he was a person who was always in the hospital, right from morning to evening, and he would devote all his time to the patients. And he was a source of inspiration. I thought to myself that if I have to become something like what he is doing with so much of passion. And he was the one who mentioned about Shankar Netralaya. Otherwise, I would not have known, because that was the era where you didn't have internet, Google, or anything. So I didn't even know that Shankar Netralaya existed. So while I was doing my internship in Delhi, although I got, a post-graduation seat in PGI and even got in other specialties, somehow my mind was, it was fixated on that I have to get into Shankar Netralaya. So I did go for the interview there, and I managed to join. And they had courses for 2 years, 3 years, and 4 years. And I said, I should take for 4 years, because I wanted to learn the most. I didn't want it to get over in 2 years. So that's how I landed up there. Initially, they had a course of 4 years for FRCS. After I joined, I realized that it was not a very specific course, and you had to make your own arrangements to take your exams. So I went to London to take the part 1 exam, which itself was quite challenging. By the time, I think, because I had cleared the part 1 DNB earlier, while I was doing internship in Safdarjung, I went and wrote the part 2, the final, and I cleared the DNB, then went on to do the FRCS. So it's been a very rewarding journey, and I think the time spent at Shankar Nethralaya definitely shaped the initial foundation of ophthalmology training. And I think that's very important. If you get the right foundation, then you just have to build up on that, and you can build up a career on that.
So from Shankar Nethralaya, how did lamellar keratoplasty came in? I remember you were the one who did that iconic first conference with hands-on wet lab with Mark Terry and
No,
Mark Danwar.
again, we were always doing penetrating keratoplasty. I had not even seen a lamellar keratoplasty being done, because only PKP was the only corneal surgery. And when I thought myself, if I have to do cornea, those were the days when, there was a big textbook of RK. So I thought, yes, maybe this will be the procedure. I'll be doing RK and I will be doing PKP. So those were the only 2 surgeries in cornea. There was nothing else. So, but then fortunately, excimer laser came in, and RK became obsolete. So we didn't have to go through all the problems of doing damage to all these eyes by cutting the cornea. When I went to do my part 1 FRC exam, and I was supposed to take the part 1 FRC off as well. So we had a duration of about 1 month gap between the 2 exams. So I spent time at St. George's Hospital in London with a guy called Chad Rostron. Now, Chad Rostron is a very, very dynamic corneal surgeon. I happened to meet him about 15, 16 years later at the American Academy as well. And he was kind enough to come and look me up and say hello. So he was a guy who had a cryolathe. He used to freeze donor corneas, shape them, and then do all kind of epikeratophakia and lamellar keratoplasty. So while in his clinic, I got to see all these patients whom he had done DALK and anterior lamellar keratoplasty and epikeratophakia. And I was amazed to see the kind of results that he had obtained. And that's when I made up my mind that, yes, we don't need to do a penetrating keratoplasty in every patient. There's an alternative. And when I came back and I read up, I realized that lamellar keratoplasty was well in vogue, even prior to penetrating keratoplasty. But because the visual outcomes were not very good, and they took a long time for visual recovery, penetrating keratoplasty became the gold standard, because the optical quality of the cornea and the recovery was much faster. And so my limitation was that I didn't have any surgical instruments to do a lamellar keratoplasty, but I didn't let go at that point of time. So I started collecting blunt crescent knives, crescent knives which have been used multiple times. So they're not sharp enough, and I use them as lamellar dissectors. So a lot of my patients who were scheduled for PKP with corneal scars, I started dissecting layer by layer till I went close to the decimates. And then I started doing lamellar, and I was amazed at the outcomes that we started getting, even with the basic training. And that's where I think the interest grew. And then when endothelial keratoplasty came into vogue, I visited Mark Terry in the US. That was just for 2 days. We spent a huge amount of money. We had to pay almost $2,600 just for watching one surgery and doing one wet lab with one donor cornea. So if you damage the cornea, you don't have another. For another cornea, you would pay $600.
Yeah,
so that was DLEK, and that also there was nobody to sit and teach you. They gave me a VHS tape, and you had to watch the video on the television and then do the same procedure on the donor cornea. But that was again a good experience. I managed to get the instruments at SN, and then we started out doing the endothelial keratoplasty. But once I started doing it, I realized that this has to be shared. We have to, that's when we did the conference, and we started reaching out to people to popularize. Initially, we met with a lot of resistance. A lot of people felt that lamellar keratoplasty was dead and gone, and it's not going to sustain itself. And this is all, whatever these fancy procedures are, they're going to die with time. But I think the concept stayed, and fortunately, now people talk about doing very little PKP, and everything they want to do a component corneal surgery, replacing that layer of the cornea which is not working. So I think that's a good evolution over the past 2 decades that we have seen.
Great. One complaint people have about you, Rajesh, is you're so innovative. You keep changing your techniques. You keep doing different things. by the time we reach there, you are somewhere else, and you. So I want to know, what is your current technique of DMEK, and can you run us through near lab, and can you take us through steps of that donor preparation as well as
Thing
the.
is, I always am in competition with myself. Whenever I do a surgery, I always try to think, how can it be done better? Is there a simpler way of doing it, making it more predictable so that others can have a smoother learning curve, so they don't have to go through the same mistakes that I would have made in the course of learning that surgery. So, and the current technique which I use, it's good, but maybe in future, if I can make it still further simplify it, maybe I'll work towards it and try to make it better as well. So I can share a near live video of the DMEK surgery that I performed. So
Yes.
it will have basically two parts. Let me just try to see if I have to open. Yeah, you're able to view the screen. I'm asking the same question. Which,
Yes. You are audible, and we are able to see the screen.
so this is the first part of DMEK surgery, that we have to prepare our donor tissue. Unlike eye banks in the US, which give you pre-stripped donor corneas, here we have to do this preparation of the DMEK donor ourselves. Although the eye bank at LVPI, the RIEB, is soon starting with giving out pre-stripped tissues for DMEK, which will make life much more easier for people. So the ideal age of the donor tissue when you are starting off, maybe use a tissue that's between 55 to 75 years old. This was a case where I had a 49-year-old donor tissue. The punch that I'm using, this is the one from Coronet. You can see that's a 9.5 millimeter punch. So it's
Rajesh,
a double punch technique
just
where
can we
I will be
pause
using the
here?
9.5 to make a partial punch.
Oh, that's 9.5, right?
Lightly, so you don't go through and through. Some of them you get the guarded punch as well. Once you have done the punch, then you need to be able to see the edge of the cut edge. So you can stain with trypan blue for about maybe 15, 20 seconds or 30 seconds. That's more than sufficient. Once you have stained, you can remove the dye, just some BSS. Now you can see that because it's a slightly younger donor tissue, sometimes if you have punched a little deeper, getting that edge of the DM can be a bit challenging. I'm going with that DM hook, and I'm trying to find the edge, but I'm unable to lift. Now, this can be challenging, especially if you use an older donor tissue, like 70, 75 years. Usually after the partial punch, the peripheral edge is already lifted. But in a younger donor, sometimes the edge of the DM is tightly attached. And if you have cut a little deep, when you try to go to the edge, you find that you are just pulling the stroma and you're not able to get the edge. In this situation, what do you do? One of the things that can be done is, you will see me doing, is that I've tried for a long time. I'm not able to get the edge. So I come with the IV needle, the 23 gauge needle. I come to one corner and I just break the DM inner to the cut. So that's where I've kind of created a break in the DM, just inside the partial punch. And then I stain with trypan blue. So now you can see that this is the area where you can see the cut edge of the DM. And that's where I'll use my hook to now start stripping the DM, because there is no cut stroma at this point. It is just the Um, I'm just rounding off the edge that I've cut. After which now when I go with the hook, so you can see that now at that point, I'm able to get the edge of the DM. Yeah, there you see. And once you get the edge of the DM, you just have to start peeling. Do you see that? So at the edge, I was not, when I was going at the edge of the trephination, I was not able to find the, so just inner to that, I broke the DM for just a 1 or 2 millimeter. And now I can easily get the edge of the DM and I can use the hook to go around and separate the peripheral DM from the underlying stroma. So this you can do for 180 to 270 degrees. You don't need, ideally you should go all around, but sometimes even if you do it about more than 180 degrees, it's more than sufficient because the rest of it will be the area where the hinge is. So we go and separate. So you can see that I'm not trying to hold the donor tissue with my left hand. I'm just leaving it there. That way I ensure that I don't apply too much of counter pressure. Because if you hold the donor tissue with your left hand using a pair of tooth forceps, sometimes you are not able to estimate how much of pressure you're applying with the right eye. And holding the free edge of the DM, I'm using a curved tying forceps. I peel off almost about 70% of the DM. And now what I'm going to do is
your vacuum on, Rajesh, this time?
Endothelial punch base, and I'm going to aspirate the fluid. By aspirating the fluid, I ensure that the folded part of the DM, it stays in place and it doesn't slide back onto the bare stroma. And it's also important that you stain the part of the DM that's already free because you can't really see the DM. And if it did slide back, and then if you use a 3 mm punch, sometimes you can punch through and through the DM. So here what happens is partially you stain, so you know where your cut edge of the DM is or the part of the DM that you have already peeled. So once you have done that partial stain, now will be the time where we use the 3 mm punch or a 2 mm, 2.5 mm dermal punch to create a stromal window. Although nowadays I don't do this step, I put an air bubble in the folded part of the DM and mark it over the air bubble. That video is also available on my YouTube channel. Most of these, whatever I'm showing, I do have these videos on my YouTube channel, so please feel free to look them up. So once you have done the punch, you can go ahead and float the DM back into position, aspirate all that fluid using a Merocell sponge to ensure that it's dry. And once you have done that, you can just gently flip over the donor tissue. This has to be in one smooth motion. Otherwise, what happens is sometimes the 3 mm punch, that stromal tissue can get left behind. So just do it in a quick sliding motion. And you can open up the 3 mm punch area, open the window. Then before you mark, it's important that you dry the fluid because if there is fluid there, when you're trying to mark with the F or the S stamp, the ink is likely to get smudged. So that's an F stamp. You can even use a Sinskey hook and mark using the Sinskey hook as well. Just lightly touch, make sure that the surface is dry. At times, you may get a complete mark or an incomplete. If it is incomplete, you can always, but don't apply too much of ink because it does kill endothelial cells, and the endothelial cell loss is usually in the range of about 1.6 to 2%. So once you have done that, now you can center the donor tissue on the endothelial punch block. And we come back and now we are going to use the 8 millimeter punch. Yeah, that's 8.5. Okay. So my usual preferred size is about 8. Sometimes in complex scenarios where the periphery has a lot of synechia, I may want to use a 7.5. And if it's a patient with relatively normal anterior chamber, I can sometimes use 8.5. But the most common size of the donor is about 8 millimeter. So once you have done that, you've punched out the 8.5, the peripheral rim between the 8.5 and 9.5 millimeter, you can just remove that, and you can now free the edge. I'm just trying to use a hook to again free the edge, because sometimes what happens is when you punch, the DM gets caught between the cut in the stroma that's been punched out. So just free that so there are no adhesions of the DM, and then you can gently catch one edge with a tiny forceps and complete the remaining peeling. It's important that you don't try to speed up the process, apply gentle pressure, and keep watching when you're removing the decimals. Once you have done that, now we can stain the DM using trypan blue. So here you can see that just ensuring that the DM is free. It's scrolling. You can see it's a natural scroll where the endothelium is on the outside and the stroma is on the inside. And then you can stain with trypan blue for about a minute or two. And then using 2 Merocel sponge, you aspirate the trypan blue dye. When you use 2 Merocel sponge, the dye kind of goes with equal force in both directions. So the DM roll doesn't get displaced. If you use a single Merocel sponge, the tendency for the DM scroll to come towards the Merocel sponge, and sometimes it gets stuck to the Merocel sponge. We then transfer the donor scroll to a Petri dish with BSS, and you can see that it's already going into something like a double scroll. And then that's a goiter glass injector that I'm using. It's not exactly a goiter glass injector. This one has been made by Janet, but it looks pretty much like the goiter glass injector. Dimensions may be slightly different. And now watch what I'm doing. I did get something like a double scroll, but I was not very happy with it. So I'm now trying to do a maneuver wherein I agitate the fluid within the glass injector, moving the fluid from the narrow part to the wider part. So currently the scroll is in a single scroll configuration. I'm just trying to see if I can open up the scroll. So when I push fluid and the fluid flows from the narrow part to the wider part, you can see that it's gone into like a double scroll, but it's more on one side and less on the other side. I could have stopped at that point, but I guess sometimes being a perfectionist is not a great thing, because then after I did that, it again went into a single scroll, and I was thinking I should have stopped before. So I'm still giving it a few more, agitations. Here you can see that it's got folded, and then I said, okay, let me just give it one more try, and you can see that with that flow, now the scroll has come into a double scroll configuration. So the double scroll configuration is the most ideal configuration to be able to insert the donor into the eye, because it makes unfolding relatively easy. So now at the other end, I attach a 5cc syringe with about 2 cc of fluid. So that's how the tissue is ready. And now we can move on to the patient surgery. If there are any questions on donor preparation, anything which is not clear, I'll be happy to take them.
Rajesh, the glass pipette, what you have, is that something which you reuse? Am I audible, Rajesh? Can you hear me?
Himanshu, I'm sorry.
Okay.
Yeah, now fine. Yes,
yeah.
go ahead.
Is the glass pipette what you're using is reusable? Do you
It's autoclavable. I autoclave it, and the current one that I have, I've been using for more than 2.5 years.
Oh wow, nice.
So unless you break it, nothing goes back.
Yeah, that's the whole thing, that the staff ends up breaking the tip and those.
Yeah, so you need to watch out for those cracks and everything, because you wouldn't want. And at the same time, not only that, you have to make sure you get this fine brush. With that, you need to clean the inside of the glass tube as well. Sometimes otherwise you can get a little bit of deposits that can build up within the glass tube. Or if you have an ultrasonic cleaner, you can put the glass tube in the ultrasonic cleaner. So any deposits on the wall of the glass tube can be easily removed, or you can soak it in detergent and make sure that you flush out everything. So it needs to be cleaned once in a while, besides just being washed with distilled water.
And the first part where you were peeling, you said you were not holding the tissue. Was the vacuum on that time, or there was no
Vacuum was not on, but I do dry the fluid between the base and the donor tissue. I don't keep any, because if there is any fluid, then when you touch the tissue, the whole corneal will move. But keep that dry, then it doesn't move. But it gives you, so if you encounter any kind of resistance while you're peeling, you can figure that out much earlier rather than when you're holding the tissue with your left hand, because then between the hands, you will not be able to judge if there is any resistance coming your way, and you end up creating a large tear.
One question is that how
We have
would
a
you...
question from the...
Yeah, Leela, please go ahead.
We have a question from the attendees, which is asking about the brand of the blue that you're using.
I use the Oro Blue from Oro Lab, and fairly good.
One question is that in younger donor, how do we prevent like little sticky tissue? How do we prevent the tear? How do we handle the younger donors?
No, younger donor, the DM is more elastic, and I think it's not as friable as what you see in older donors. The only problem in younger donor is sometimes getting the edge to separate. And also when you peel, it takes a little bit more force to separate the DM from the stroma, but the tissue, the DM itself is more elastic, and it tends to curl up pretty quick. So some surgeons like to stain that DM for a longer duration of time, even up to 3 to 4 minutes. They believe that staining for a longer duration of time using trypan blue kind of reduces the elasticity of the DM scroll. Thereby, the tendency for the scroll to go into a tight scroll formation is a little less.
Even the endo in technique, what Busin does, the
Correct.
double questing, somehow that actually makes the tissue less elastic. I don't know whether it breaks those elastin fibers or God knows what it does, but it makes it little less elastic.
Possible. I have had very limited experience with endoing. I must have done about 20, 25, 26 eyes with endoing. It does work, but I have not found any difference in the endothelial cell loss between doing endo out or endo.
Behavior of the tissue. Have you found any difference there? No.
It's a little bit because you use the AC maintainer when you are inserting. Sometimes it's difficult to control the tissue, and if you're not very careful, your tissue can flip over, and so it can basically, it's a little bit tricky to use. It's not as simple, because unlike a DSEK tissue, which has some volume to it, a DMEK tissue, it doesn't have any volume. So, so if your flow is not directed properly, or your nurse forgets to stop it or reduce the flow at a point of time when you need it, you can have the tissue going to the opposite angle, getting flipped over. And if you have not marked it, you can clean it up.
Any other question anybody has?
If the edges are not very smooth, like we create some defects in the edges while lifting the DM, does it have any bearing on later on while inserting it?
A larger refine, like a 9.5. So if you do get some ragged peripheral edges and all, the punch that you use, an 8 millimeter, you can slightly make it eccentric one side or the other to get those ragged peripheral edges away. But even it's not necessary that you have to put in a perfect circular tissue. Sometimes in some periphery, if there are one or two radial tears, or if there is a little bit of loss of tissue at one edge, it will still work. You may be transplanting lesser amount of cells, but it doesn't affect the overall performance of the tissue in performing DMEK surgery.
Okay, so if there are no other questions, we move on to the next segment. And before we move on to the next segment, Rajesh, I'm going to touch up with a little bit about now your family and this thing. How important is role of your family in your professional and personal life? How do you balance them? How do you handle these things with your such extensive, busy schedule, traveling and everything. And also, I would want you to touch upon these two lovely your kiddos. So tell us something about the family values and how do you handle.
Support of family is extremely important, because without support of your family, I don't think it would be possible to find time and do all the things that you want to do. So somebody has to, because in a family, everybody needs time. You need to give time to your kids, you need to give time to your wife. And if you have pets, you need to spend time with your pets. So whenever you're away, you're taking away the time that is meant for all of them. So somewhere we have to compromise. And I think that's only possible because for me, my wife plays a very important role, because while I'm away, she takes the role and does all the things that I'm supposed to do. And I think in our profession, women definitely deserve a lot of appreciation, in the sense that they play dual roles. They're not only ophthalmologists, but they also have another job at home, managing the family and managing the husband and so many other things. So it's a combined effort. I think that plays a very important role in this.
Thank you. Bela, you want to take him up with the work-life balance part?
When do you feel more relaxed, Dr. Fogla? What is your meditative state? When you're operating, or when you're cycling, or when you're running the marathon?
Oh, it's equal for all of them. When I'm operating, I'm totally involved in what I'm doing. So for me, I tell my wife that you just see the patients in the OPD, and I just go to OT every day. And I just operate. So all the pre-ops and post-op you take care. I'm happy operating it. Same thing when you want to go for a marathon or you want to go for cycling. At that point of time, nothing else comes in your mind. So if you're running, then you're running. If you're cycling, then you're devoted only to cycling. I think you have to find your comfort zone, and you can't mix up all the things. And finding time for the other two activities, practice, it takes a lot of effort. And I would say that in my formative years, once I finished my initial part of your career, one may find it very difficult to find out time for all these activities, because you're just starting out, so you want to devote more time to your clinical practice. You get married, then your kids are small, your kids need more time. You can't be away from them and do all these things. So for me, all these activities started maybe when my daughter grew up. And I would say in the last maybe 5 or 6 years, I have taken up running, cycling, and all these things, because maybe I have more time. I have spent enough time in my career. I have established my practice, so I am more comfortable in that area as well. But I think but I see a lot of when I go cycling, I meet fellow cyclists who range from 19, 20 years all the way up to 60, 67 years. And the senior ones are somebody who have finished and they are retired, so they come and they spend more time doing that. The younger ones who are there, they work, but at the same time, they want to stay fit and they want to do these activities so that, it helps them maintain themselves. And I think currently the younger generation is more aware about fitness and they try to devote time doing these activities. Maybe in our time, from our childhood, we never gave importance to, these kind of activities. So we were only told to study and become a doctor and, just work and focus only on work. So I think all work and no play makes Jack a dull boy. So once you find these kind of activities, I'm pretty sure you will find them very, very relaxing. And it takes your mind off. Like I was away for a week in Meghalaya for cycling. I don't think that 1 week I ever thought about my patients or anything else. Although I did call up my wife every day, I can't forget her. But then in terms of doing my other work, I was able to just enjoy cycling and just, come back refreshed after a good vacation. And I think that's very mandatory. A lot of times people don't realize that how important it is that you spend time with yourself. So you have to take a break. You have to, go for whatever you feel good, whether it's traveling, whether it's, taking your family for a vacation, or like for me, even cooking is a stress buster. So if I've had a very tiring day at work, Sometimes I just come back home and I go to the kitchen, listen to music, and I cook something, and that takes my mind off everything else. And I find that very relaxing. So it's important that you find what you interests you, whether you like playing music or you singing or anything else. I think it's all in your hands. We always keep tending to say that, oh, I'll do it later, but that later will never come. You have to say that it's now, and I'm going to do it.
Rajesh, when we talk about such kind of activity, you said you started late, but what do you suggest for youngsters? Do you suggest that get established in the career and then start, or you wish you had started this earlier?
I wish I had started this earlier. See, nowadays it's very easy, whether you look at Facebook or you look at in every city, there are groups of people. Starting solo is a little difficult. If you started to say, I'm going to run every day, you will do that for a few days and then you will stop it. Like in Hyderabad, we have a group called Hyderabad Runners. So when I started running, I could barely run, but I joined that group, and they used to do these runs on weekends. And their runs are like, for different category of people, like 5 kilometer, 10 kilometer. So when you go and run along with other group of people, I think that motivates you and you're able to perform better. And, so it's the same thing with cycling. I started cycling with the bike affair. So these guys also have these rides on Saturdays, Sundays. So you go in, you meet new people who are not ophthalmologists. So definitely you don't end up discussing the same thing over and over. You talk something else and you go around with them. And although initially your performance may not be great, but I think with over a period of time, you will improve. And I think then you find that later on, even if you want to do it all by yourself, you can still do it. And if you don't do it, sometimes you feel lethargic, So just make a start, I think, but don't go all out in the say that, oh, I'm going to run a half marathon tomorrow. That's not great. That's not going to happen. But at least start walking, then do walk, run, walk, then you start running. So I think that's how you're going to achieve it. And I know of a lot of people who have started running and cycling, and they are doing pretty good.
Maybe we'll go to the next part of your talk, Dr. Fogla.
Yeah, so since we have
and then come back.
prepared the donor tissue, let me just try and share the surgical video. So the common indications for DMEK surgery are basically Fuchs dystrophy and pseudophakic bullous keratopathy. These are the two most common indications, and they are the best cases to start with if you are starting with DMEK surgery as well. So this is a patient with pseudophakic bullous keratopathy. The anterior segment is relatively normal. The pupil is round and central. There is no peripheral anterior synechiae. To improve the visualization, we remove the edematous epithelium and do a debridement. You can use a Merosel sponge, or you can use a hockey stick knife. You can use a crescent knife as well, but it's very sharp, so be careful, because if you're not careful with the crescent, sometimes you can end up making cuts on the corneal surface. And if the long-standing corneal edema, it tends to bleed as well, because there is peripheral superficial vascularization. In such cases, I put a drop of brimonidine, which helps control the bleeding. And you can also put some HPMC on the surface that ensures that the bleeding that happens, it doesn't come onto the central part of the cornea and remains in the periphery. So once you have removed the epithelium, you can go ahead, make your, that's just a 8 millimeter mark impression that I created, so that I know where I have to do the descemetorrhexis. Then we make 2 paracenteses, and these paracenteses should be large enough to allow easy access to the anterior chamber. If you make very small paracenteses, what happens is later on, when you need to access the anterior chamber, you find that with your cannula, you are struggling to get into the anterior chamber. And at the same time, don't make them so large that when you do a complete airfill, the air keeps leaking out. And then I put in some meiotic pilocarpine, and you can see that that constricts the pupil. And after which we'll be doing the decimet stripping. So I go ahead. I like to do my DM stripping under cohesive viscoelastic. So we fill the anterior chamber with sodium hyaluronate. You can do the stripping under air as well. The problem with air is that as you start doing this decimeterexis and the stripping, you end up releasing the air, so you have to repeatedly go and keep forming the chamber. Unless you connect a AC maintainer, which is connected to an air-filled syringe, and you can have your assistant keep injecting air whenever the air leaks out. If you do your DM stripping under air, you find that the contrast is the best. So if you have a very edematous cornea, maybe doing it under air definitely has its advantages. So this is a DM stripping hook that I have. One end is like a olive tip, and the other end is round tip. I use the olive tip end to break the decimates. And it's important that you don't apply too much of pressure. The decimates is very fragile. It will break with gentle pressure as well. And watch out for the previous side ports and the main incision, because often you end up opening up those incisions, the internal part. And the addition of the decimates is also a little tighter around these points because of fibrosis. So when you're stripping out the DM, you will find that at those points, you have to really work hard to get the DM to. So that's a 2.8 keratome. I've just enlarged the incision to 3 millimeter. Now I go ahead with my DM stripping hook. Now I'm using the rounded end to kind of get the edge of the DM to separate. After doing this peripheral break in the DM, you can even wash the anterior chamber with trypan blue, which also stains the cut edge so that it improves your visibility. So you can see that in pseudophakic bullous keratopathy and Fuchs, you will find that the DM is sometimes thickened, so it becomes relatively easy for you to strip and remove. But conditions like toxic anterior segment syndrome or post-viral endotheliitis, the DM is thin and it can be very tightly adherent. So sometimes instead of coming out at one piece, it comes out piecemeal. Now here I'm just trying to see those peripheral small tags which are there, removing it. It's nice to have a micro forceps because sometimes the peripheral tags that you have, you have to remove them, because if you leave them behind, number one, it can interfere with your unscrolling of the DM, and sometimes if it remains in the interface, it may hamper the adhesion of the DM to the stroma. And if it remains beyond the edge of the trephination, the tags, if they are in close proximity to the iris, they can be a focal point for developing peripheral anterior synechiae. And to be able to visualize these tags better, like I said, you can flush the anterior chamber with trypan blue, but not for long duration, just for 50-20 seconds. If you keep the trypan blue dye in the anterior chamber for a longer period of time, your bare area of the stroma, from where you have stripped the DM, will also get stained with trypan blue, so which will again hamper your visibility. So that's the previous site of the main incision for the cataract surgery, from where I'm peeling off the DM, which was kind of tightly stuck. So once you have removed the DM, the next step is that we do our inferior peripheral iridectomy. I still have the viscoelastic in the anterior chamber. You can see I have the vitrector. The cutting is about 200, vacuum is 250. The anterior chamber still has viscoelastic, so I don't really need to irrigate the anterior chamber. I go ahead, I make a few cuts. Don't cut for too long, because then you will break the zonules and might eat up the vitreous as well. And that can create aqueous misdirection, in the sense that fluid from the anterior chamber can go into the vitreous cavity as well. I'm putting my cannula through the pupil behind, just to, like, I'll just show that once again, to ensure that my PI is complete. I will just go in with the cannula below through the pupil, and I reach the area of the PI. And if I can see my tip, then I know that my PI is through and through and not a partial peripheral iridectomy. So once you have done that, then you can, there will be sometimes a little bit of bleeding, but it stops. If it bleeds a lot, you can put in a large air bubble and just wait for a couple of minutes. That's sufficient. And then we go ahead, I place a suture on my main wound. I like to secure the wound once my donor is inside. And after I put the suture, I will go ahead and wash the anterior chamber of the viscoelastic. You can do that with bimanual IA. You can use a IA. I like to use a Simcoe because the curve of the Simcoe allows me to really vacuum the undersurface of the cornea. So I don't want any residual visco sticking to the inner surface of the cornea. So with the Simcoe, I can really go and vacuum the inner surface. And once you have done that, then I'm going to do I'm just going to suture this wound, the temporary stitch, that's the AC maintainer in place. And now you can see that that's my injector with I look at where the open end of the scroll is. That means if I go bevel down, once I'm inside, how much I have to rotate the tip so that the open end of the scroll is facing up. I go in, my AC maintainer is on, I go inside. Once I'm inside, I rotate so that my open end of the scroll is facing up. Now my nurse will discontinue the AC maintainer and disconnect it from the IV tubing. So now you see that I have injected my scroll into the anterior chamber. The chamber is shallow because the fluid has leaked out from the AC maintainer, and there is no tendency for the scroll to jump out of the eye. So there is no risk of partial or total expulsion. Now, before I go and manipulate the DM scroll, I will just secure the wound. Remember, the eye is a little soft at this point of time. So often what happens is the suture that you place, it's a little tight. So don't yet cut the suture, just leave it like that. And now I'm going to come and do the unfolding. So you can see that a double scroll, the unfolding is relatively simple. The chamber is very shallow, so I'm just putting a little bit of fluid just to partially deepen it. And now you can see that as I go with my cannula, and I'm just giving it another, so making it mobile. And now you can see that I just tap in the periphery. If I release a little bit of fluid also, the tissue opens up. I'm going to center the graft because it's moved to one side. So I'm using the two cannulas to tap and move it towards the left. Once it's in position on the left side, I just don't be in a hurry to remove the cannula. Just slowly remove it, because if you remove it too fast, then it's going to come back on the right side. Now I'm going to secure the open end with one cannula, and I release fluid from the other paracentesis to kind of a little bit shallow the chamber on that side, and I tap, and you can see the graft is open. You can see the F stamp. So in real time, this has not even taken more than 1.5 minutes to open up the scroll. And once we are sure that our graft is in the right orientation and well centered, you can just tap a little bit more. I'm just trying to move it a little superior. Sometimes the upper edge will engage the inner lip of the wound. So that's why making a scleral tunnel is sometimes better, because your inner lip is more peripheral compared to a corneal wound. Now I go in with my saline cannula and I inject some fluid onto the iris surface just to get the iris to fall back so that there is space between the donor and the iris. So I can introduce my 30 gauge cannula, which is attached to a 1 ml syringe, having only about 0.1 to 0.2 cc of air, and I put an initial air bubble. And you can see that that air bubble secures the donor in place. Once I have done that, I can always go back and, inject a little bit more air to completely fill the chamber. So that's a complete air fill. Now the suture that I have placed, sometimes it may be a little tight. So what I like to do is I just hold the suture, I cut it, I pull it out, and now I can reapply my knots. So then with a completely formed chamber, my suture tension will be right, and it will not cause any dimpling of the cornea at this point of time. If you have put a tight suture and your cornea is dimpled at the point of the main incision, sometimes that can also be a factor why your donor DM does not stick very well in that area, because the inner curvature is not a smooth curvature, there is a bump. So this ensures that you don't induce astigmatism and you have a perfect wound. So that's pretty much the surgery. It's taken, the entire surgery is only about 13-minute duration. So you can see the DMEK truly stands for definitely most easy keratoplasty.
Great. Dr. Nivedita is here.
Yeah.
Nivedita had one question. Nivedita, you are there?
Yeah, I'm here. You can hear me?
Yes, we can hear you. Can you ask your question?
Yeah, very nice explanations all there. My question is, very often I get peripheral tags, especially in the tough cases, where sometimes you may be able to remove, sometimes they are very fibrosed, the host disc flaps in the periphery after descemetorrhexis. So what is the best way to manage them? If you cannot strip and
Yeah,
you
sometimes
will have a
in
detachment or something.
those scenarios, you will need a micro scissors as well. Because in complex scenarios, you have fibrotic DM. And if you forcibly try to peel off that DM, what happens is it goes all the way to the trabecular meshwork and it can induce a lot of bleeding as well. So in those kind of scenarios, sometimes I use bimanual technique that I'll have a micro forceps in one hand and a micro scissors in the other. And I fill the chamber with viscoelastic and I go and I cut out these peripheral tags and remove them from the eye. So you can do that using a McPherson and Warner's as well, but then you may have to slightly enlarge your main wound to be able to do that. But yes, peripheral tags often need removal. And if you don't remove them, the recurrence of peripheral synechia can be quite big. Sometimes you can use a vitrector as well. If you don't have access to a micro forceps or a micro scissors, you can try using a vitrectomy probe and you can go and chew up these peripheral tags so that you can minimize the contact between the tag and the iris tissue.
Thank you.
Thank you. What if the DM totally separates?
Yeah,
The
so
total decimates of the...
you have when you just try to pull instead of tearing or instead of breaking it, the whole thing just peels off almost to the trabecular meshwork. So that is when you have to use a scissors to kind of cut the decimate, the fibrotic DM, and remove it. If you don't have a pair of scissors, you have to be innovative. And sometimes you can use an MVR knife to one of the side port and use that MVR knife to kind of create like a beer can or a punch holes in the DM and try to break it and remove it from the eye.
Okay, next, Dr. Nikhil. Dr. Nikhil, you are there? So Nikhil had a question. Now, what is the specular threshold to plan primary DMEK with cataract in patient with Fuchs endothelial dystrophy?
Anything less than 800 cells per millimeter square ideally should require a combined surgery, but I look at more at the pachymetry than the absolute endothelial cell count, because sometimes you have patients who have cell counts of 1100, but the pachymetry is over 700, so they do need a combined surgery. My patient about early morning blurring of vision. If they have early morning blurring of vision, then that means that the cornea is already decompensating.
Himanshu sir, I am here. I would like to hear from sir.
Yeah, Nikhil, he just answered. Do you, so he said that 800 cells per millimeter square is his cutoff.
That a lot of these post-peak AIs where you are doing a cataract surgery, they may have cell counts of 500 or 600, but the pachymetry is still in the range of 480, 490, and we safely go ahead and do a cataract surgery in the eye. But in a Fuchs eye with guttate changes, the rest of the endothelium is unhealthy. So there, even if you have cell counts of 1100, 1200, and if the DM is thickened on anterior segment OCT and the corneal thickness is more than 600, 650, I think that's an indication for a combined surgery. So I think you'll have to take everything into account and then plan for the decision making.
Okay.
Dr.
So
Gunjan Shah, are you there?
One more question I had just posted, sir.
Sure.
Nikhil, can we
Okay.
just finish those who had sent in advance, because it's unfair. We have been asking for question for a very long time. We'll finish those who have given in advance.
Sure,
Then
sure,
we'll come to okay. I'm really sorry. Those who are typing question, please bear with us first. Those who have sent in advance, we'll take that, and when we have time, we'll come back to your questions. Please.
Thank you.
Dr. Gunjan is there. Okay, so Dr. Gunjan Shah had a question that can we give pre-op mannitol before DMEK? Is it required? And what do you suggest about that?
Well, if you feel that the patient has a very shallow chamber and you need some working space to be able to do your surgery, you can consider, but ideally in a DMEK scenario, a shallow chamber is to your advantage because kind of a shallow chamber assists in your unfolding as opposed to a deep chamber where the DMEK roll keeps going into a scroll and unfolding can be a challenge. But like I said, if your clinical case demands it, you can give, but I don't routinely use mannitol in any of my DMEK cases.
Okay. Charuta, you are there? Charuta? Okay, so Charuta had sent. Yeah, please, Charuta, go ahead. Can you ask your question, please?
So I think the case which I shared was having prior vitrectomy done, a fake kick.
Should I read out for you?
I think she is having connection issues.
Okay,
maybe.
so she had asked that the patient is aphakic with large superior sector iridectomy with diffuse epithelial edema and increased corneal thickness. Vision with correction is 20/40, nil systemic illness, primary surgery detail not available, no glaucoma, no retina problem. What would be your approach in this patient? Large sector iridectomy, aphakia, vitrectomized eye.
Well, it all depends. If she's saying that the patient already has diffuse epithelial edema, which indicates that it's a cornea that's failing despite the vision being 624?
20/40.
So, yeah.
Well, yeah, so it depends on the fellow eye as well. If the fellow eye is phakic, and obviously you need to do something for the aphakic correction, RGP contact lens can be tried if the patient can tolerate it. So temporarily that can manage the anisometropia between the eyes. And if the patient is not willing to wear a contact lens, then I think the next option is to consider doing a secondary IOL implantation. I would do a flanged IOL implantation, maybe a 6.5 millimeter optic. If the sector iridectomy, the iris is mobile, maybe try to do some sort of pupilloplasty. If a pupilloplasty is not possible, I think in this scenario, an ultra-thin DSEK would work pretty well. DMEK can be done, but it can be a little bit more challenging because post-operatively, it's a superior sector iridectomy. So retaining the air or gas in the anterior chamber will be a challenge. But with ultra-thin DSEK, if you can retain the full chamber on table and just for a short while after the surgery, later on, even if the air goes into the vitreous cavity, the ultra-thin DSEK graft will still stick very well.
Great. Dr. Shilpa Joshi is here.
No.
Okay, so Dr. Shilpa Joshi had a question. What is the best method to unscroll a DMEK graft, especially if the S stamp is not visible?
Well, in the first 6-7 years of my DMEK surgeries, I never used any kind of mark on my cornea. So I used to stain the DM with trypan blue, go in and, so the only clue was to look at the edge of the DM, and it should be the DM should be curling towards the surgeon. So, that was the only way to figure out. And you could rely on the Motsuri's sign as well, where you try to put in a cannula into the scroll. If the cannula turns blue, that means the cannula is, the tissue is scrolling towards here. So you can still do that. If you have a faint S or an F stamp, sometimes you can switch off the microscope light, use a light pipe, and against that tangential illumination, you can still visualize the S or the F stamp. So I think that's there. If you have intraop OCT, that's again a great device which can tell you in what is the orientation of your graft. And in rare situations, you can even restain your DM scroll while it's in the anterior chamber. You can always inject a little bit of trypan blue for 10-15 seconds, wash it out. And if your trypan blue is fading from the DMEK scroll, you can visualize that. But like I said, that yes, for a beginning surgeon, it's always important that you have a nice F or an S stamp so that the orientation part, you're not confused. Otherwise, you always have sleepless night. You go back and you start thinking that, most likely I put it the reverse way. Until the next day you see your patient on slit lamp, you're always wondering, what exactly did you do during the surgery?
Thank you. Dr. Reshma Mehta is here. Okay, so Dr. Reshma had a question. I have a post-operative case who has severe striate keratitis, DM folds. I don't think the cornea will clear with medical management. Can you suggest which is the best time to post him for corneal surgery so as to preserve his vision? It's 13-day post-op. So how early do you go in? And
see, so when you have corneal edema post-cataract surgery, you have to be very clear about the etiology of the corneal edema. If it is just a hard cataract and you have striate keratopathy, you can wait for 8 to 12 weeks and give intensive steroid hyperosmotics like 5% sodium chloride, and you see the progress clinically. And one of the ways to look at is serial pachymetry as well, and see over a period of time is the cornea recovering. But if you are pretty sure that you have lost the DM during surgery, or if you have had a toxic anterior segment syndrome where something has been injected into the anterior chamber and all the cells are non-viable, then there is no point in waiting for several weeks, because the cornea is going to become more edematous, and the more the edematous the cornea, the longer it's going to take after the surgery to clear. So in that scenario, if you are definitive that the endothelial cells are not functioning or the DM is lost, then you should go in as early as possible and do the endothelial keratoplasty. Unless there is severe inflammation post-cataract surgery, then maybe you would want that inflammation to settle down before you go in and go ahead and do a DMEK.
Okay. There's one question by Dr. Manvi Agarwal. If she's here, she can ask. Otherwise, her question was that what do you do differently in DSEK or DMEK with cases like ACIL, post-VR surgery or aphakia compared to a normal DSEK?
Well, I think all these situations, the complex scenarios that you look at, whether it's an eye with an anterior chamber IOL, where you may need to see whether that ACIOL is stable or not. Is it undersized? Is it moving? Or the ACIOL is the primary cause why the corneal endothelium has failed. Then you may have to plan for an IOL exchange. In a vitrectomized eye, again, whether depending on whether the pupil is central or there is a large iris defect, you may have to think about doing some sort of pupilloplasty so that you can retain the air in the anterior chamber for the tamponade. Secondary IOL, if it is aphakic, you may have to plan for a secondary IOL. Now, sometimes you can do them all at once. And in certain scenarios, maybe it's better to do in a sequential manner. That means you first get the secondary IOL and the pupilloplasty, everything done, and then come back and then do an endothelial keratoplasty, which actually may be better because the overall manipulation of the eye is less for the endothelial keratoplasty.
Great. One question was role of stromal augmentation. This was asked by Dr. Lakshya Dudeja. How do you perform in your practice, and which are the cases you select?
I did stromal augmentation using stromal lenticules with the Bowman membrane back in 2015, 2016. We did about 12, 13 eyes, followed them up for several years. But somehow I was not very, it did help increase the thickness of the cornea. It helped stabilize the keratometry. The only thing it did not improve was, it did not improve the vision significantly. Some of these eyes we did topo-guided PRK, where the vision did improve compared to what it was pre-op, but it never achieved the kind of vision that you would desire for your patient. And even if I recently at the World Cornea Congress and the American Academy, I met Vardania Kuchaba from Melissa's team, and they've almost given up doing Bowman layer transplantation. So they are only doing Bowman onlay transplantation. So they are no longer creating a pocket and putting a Bowman's layer inside the cornea, but they are debriding the entire epithelium, putting the Bowman's layer on the cornea, waiting for about 40-45 minutes for the Bowman's layer to dry and stick on the cornea. Then they put a bandage contact lens. And that, according to them, works better. And that's their preferred procedure of choice for advanced keratoconus. The problem with stromal augmentation is not the ability to put in a stromal tissue into the corneal pocket. The problem is you create multiple interfaces. So your light, as it goes through the cornea, through the front part of the pocket, then through the tissue, then the posterior part of the pocket, and then through the cornea, I think it scatters a lot, and thereby the quality of vision is not too great. In these eyes, even later on, if you try to put a contact lens, they don't see as well as what they would have seen without the stromal augmentation. So this is something we really need to work on. Maybe the stromal augmentation peripheral, that is the Kyre's procedure that Susan Jacob has been proposing, is like a stromal augmentation. It's not exactly like a intracorneal ring because it doesn't have the rigidity, but it's kind of a peripheral stromal augmentation. The advantage of that is the visual axis is spared. So you are putting the augmentation outside the visual axis. So the visual axis, your light is not getting scattered. So that's why maybe that's something we really need to work on, is a segmental stromal augmentation without involving the visual axis.
Good. There's one question by Dr. Nandini. Nandini, you are there?
So I wanted to know, when we are doing manual dissection during DALK, if there is perforation. One scenario when you have central perforation, which is small. Other scenario, peripheral, maybe little large, maybe 3 mm. So how to go about it? And one more thing is, I want to know at what level you will stop your dissection when you are doing manual DALK. Like, I have done enough dissection, now I am going to put graft. That's all, sir.
So I think the key factor in doing a manual DALK, I feel the most important step is getting a nice deep trephination. So you need to use either a guarded depth handheld trefine, like a 350, 400 microns, or you use a suction trefine and go at least 6-7 quarter turns. So you get a nice cut that goes up to 400, 420 microns. So once you have a nice deep trephination, then the objective is to try and get the dissection that matches up with the base of the trephination. So that you can do in multiple layers rather than doing it in one layer, where you can debulk the first 30-40% of the tissue, then come back to the periphery, make a pocket all around, or at least for 270 degrees, and then you can do the Malbrun's peeling technique. And if you are at a deeper plane, the peeling will happen relatively spontaneously without too much of dissection involved. So once you feel that the tissue is peeling spontaneously, then you know that you are deep enough and you don't really need to dissect anymore. Doing the dissection in several quadrants, piece by piece, does not give you a uniplanar dissection. So the key factor is create a plane in the periphery and then just peel off the tissue so that the central cornea is a uniplanar dissection. So I think that's what I have been doing, and I have been fairly successful in getting reasonably good results without any kind of complications. Like the perforations that you're referring to often happen when you're trying to do this multiplanar dissection. That means you're trying out different instruments to create different planes, either using a spatula or you're using a Vannas scissor or something to create a plane segment by segment, and that kind of ends up creating a perforation. So working in the periphery, the advantage is that because you initiate your dissection in the periphery, even if you were to perforate, the perforation will remain in the periphery out of the visual axis. And wherever you have a perforation, in that quadrant, you can always place a suture through the stroma and start your dissection in the opposite quadrant after placing a small air bubble in the anterior chamber. The air bubble basically acts by tamponading the break and preventing the egress of fluid. Otherwise, what will happen is the fluid will keep coming out onto your surgical field and hamper your further dissection because you won't be able to see the plane you're dissecting. So I think these are small tips that you can use to successfully complete your manual DALK.
Thank you. I think that also answers Dr. David Dea's question of tips about manual DALK. I think Dr. Gunjan Shah's question also you took up, which was secondary IOL and EK. What is your preferred choice of secondary IOL?
I think it all depends on the experience of the surgeon. Even a retro iris claw situated IOL works quite well, provided the enclavation is done properly. You can do Yamane technique, or you can do a 4-flange technique, or if somebody is comfortable doing a Gore-Tex suture fixated IOL, that also works very well. So ultimately, it depends on the experience of the surgeon doing the secondary IOL, who can do a reasonably good job to ensure that you have a stable IOL, which is not tilted, Sometimes you put in a secondary IOL, but instead of remaining horizontal, it's kind of tilting in one direction or the other. And that gives you suboptimal visual outcomes.
Okay. One question, which though you have taken up in detail about work-life balance, but I would still want Dr. Pranita Matani, if she's there, to ask. She had a little specific question about that. Pranita, you're there?
Yes, sir. Good evening, sir.
Hi, Pranita. Tell me.
Sir, this is a very non-academic question, actually. But like you touched upon it earlier also, that, you wish that people tried to get a bit of work-life balance earlier on. So, as a resident or somebody who's starting, like, going to enter fellowship and really like the infancy of a career, where your focus is all on your career, like how do you
If
try
I was
and
working at a place
how
like,
do you
if I was continue to work at a place like a tertiary care institute like Shankar Netralaya or LVP, I'm sure the workload will be so much that I will not have too much of time to think about all these
Yes, sir.
unless I do it on weekends or on holidays. But to do it on a regular day basis, you have to be really committed to find time. And I know of people who still go to the gym maybe at night, 9 o'clock, 9:30, they do it because they are passionate about it. There are groups in my society who go to play badminton at 4:30 in the morning. Nearby, there's a badminton court that rents out on an hourly basis. They go and play 4:30 to 5:30. I sometimes used to play tennis in my society. I play at night, 9 to 10 under floodlights. So I think it all depends on what you want to do. If you want to sit and watch TV for an hour at night, then that's fine. That also you do. But if you really wanted to go out for a run or for a walk, you can still do that. But the thing is, yes, if you are overloaded with work, especially when you're a resident or you're doing fellowship, it may be a little bit more tighter to be able to do that. But I think it's still possible. It just depends on what exactly you want to achieve.
So
Thank
Mona,
you,
you're
sir.
there? Mona, you're there? Okay, so Mona had a question. How can, if we are doing DMEK and if we find that the graph is decentered and it's really decentered, how do we handle that?
Well, it happens.
There you go, Mona. Sorry, I thought you're not there. That's why I read it out.
No, it's okay. Hello, sir.
Yeah, hi.
As usual, nice videos, sir.
Thank
Lots of learning from them.
Sometimes it does happen in DMEK in the sense that you have a situation where you struggle to get the graft to open, and after a lot of manipulation, the graft opens up, but then you find one edge of the graft is in the angle and the other has opened up and it's very close to the visual axis. And no matter how much you manipulate, because the graft is now kind of stuck to the cornea, and you really are not able to move the graft by external manipulation. And if you really deepen the chamber to detach it, then what happens is it'll go back into a scroll, and you have, with a lot of effort, you have opened it up. So in such situations, I have also gone in with a microforceps. I have caught one edge of the DM and I have just pulled it to kind of center it. So that can be done. So, but again, you have to be sure that once you hold it with a microforceps and pull it to the center, before you remove the microforceps, your microforceps has to let go of the DM. Because if you don't do that, sometimes if the edge of the DM is still stuck to your microforceps, when you're removing the microforceps, you might pull out the DM through your side port as well.
And sir, like if the AC is deep, is it difficult to move the graft? Because once or twice off late, it has happened that the graft initially...
If your graft is already partially stuck to the stromal surface, then like you put a small air bubble, or if it has, the AC has been flat, the DM can get stuck to the undersurface, the inner surface of the cornea. Then even if you keep your chamber deep, sometimes the graft will not detach or not move unless you irrigate the interface to separate the DM from the stroma.
Okay, and which microforceps should be used? Because the graft should not get down.
I use the MST microforceps. So that's an investment you need to make. I have the MST forceps with the micro scissors, micro grasper. So that's kind of pretty good. Otherwise, you can get some forceps from ASICO. ASICO is now part of Coriza. That's the same Catena, ASICO, everything has become one company. Or you can try and look at some forceps from Joja Surgicals or from Indo-German. They also have, or Epsilon, and invest in a good forceps preferably a 25 gauge forceps.
Can an ICL forceps be used?
It's too big. It's meant for holding ICL, and ICL is quite thicker than the DM. So maybe a finer forceps than that would be much better.
Okay, because of late it has happened once or twice that the graft is decentered quite a lot and it's not happening in correct position. So it's to decide whether to disengage it again and again do it, because that increases the time and then fibrin starts building in the AC.
One question is from Meena. Meena, you're there?
Yeah, Himanshu, good evening. I'm there.
Please go ahead, Meena.
Yeah, Dr. Fogla, thank you so much. And my question was, recently I had a surgery where intraocular fibrin was holding the edge of the graft. Eventually, I did overcome it, but I want to learn from you how to use the plasminogen activator. I've never used it.
Even I've never used it, but I know of my colleagues in the US who use enoxaparin in their BSS solution, and they use it to dissolve the fibrin. For me, I think what the surgical technique we use is before we insert the donor into the eye, often after the inferior PI, we'll do a complete air fill and we leave it for a few minutes by the time you're loading your graft or other things, and then come back and remove the air bubble and also wash the anterior chamber at the same time. So what that complete air fill does is any bleed that's happening or any fibrin that's forming, it arrests that. And after that, if you wash the anterior chamber well, then basically you are removing all the fibrin and you can avoid facing a situation where your DM scroll is stuck in the fibrin. But yes, if you have bleeding from the iris or bleeding from the angle or from the iris structure, and then you have a scroll in the eye and you manipulate it for a longer duration of time, sometimes the fibrin can create fixed folds, and in those situations, no matter how much you manipulate, you find it difficult to unfold. So in that situation, I think it's about 40 units that you use in your body.
So Bela, you had question. Can you ask Bela questions which you wanted to ask?
My network is actually creating a lot of problems, so I was just.
So Bela had asked that transition from DSEK to DMEK. What are the tips and tricks, and how do we do that?
Well, I transitioned from DSEK to DMEK back in 2009. And let me tell you frankly that when I did the first DMEK, everything went off like a piece of cake. The first patient did so well. And I thought, oh, this is so easy, this is a great procedure. But then as you started doing more and more, my nurse used to tell me at the end of the day, sir, I have to go home. Why don't you do a DSEK? Because I used to be struggling for 40, 45 minutes trying to graft to open, because I was using all the principles of DSEK on DMEK. I was keeping a very deep chamber and I was tapping with one forceps, and the deep chamber, you know how the graft behaves. It opens, it closes it. So I think, and at that point of time, there were not too many instructional videos available on YouTube, or not many people were doing DMEK. But at this point of time, with the kind of information that we have on DMEK and with courses going on at institutes and even this online EKLG group that they had. So I think there is a wealth of information that surgeons have, and which can make their transition from DSEK to DMEK very, very simple. In fact, DMEK is a easy surgery, I would say. I think it's even easier than doing DSEK.
She was asking, do you suggest to keep two
tissues while
not necessary, but like I said, that if your eye bank starts giving you pre-stripped tissues for DMEK, then there is no need to keep two tissues, because you already have a tissue that's been prepared. All you have to do is to punch it, stain it, load it, and inject it into the eye. Previously, when we used to be preparing the DMEK tissue ourselves, that used to be again like an entire surgery, because you're so scared that if I tear this tissue, then I won't be able to complete the surgery. So we used to always do that before we take the patient in. So in that scenario, maybe yes, you sometimes need to have a second tissue. And when I started doing my DMEK surgery, I used to counsel my patients about the advantages of DMEK. But at the same time, if that DMEK doesn't work, or for some reason, if it has failed, I used to go back and do a DSEK on the eyes because, the second procedure has to be more definitive. You can't be doing another DMEK on those eyes.
Another practical thing now, being in private practice, do you charge for the next procedure that you do?
Do you charge for that?
Do you charge for the other procedure that you do? A DMEK, you counsel the patient for a DMEK.
Yes.
It doesn't work and we have to do a DSEK. Do we charge the patient?
Yes, we charge the patient for the next procedure, but we don't. So basically, they pay only for the consumables. We try to waive off rest of the charges.
Great. I think we'll take the last question, and which is by Dr. Jayanth. Dr. Jayanth, are you there, Dr. Jayanth?
Yeah, sir. Hello, sir. Good evening.
Hi, good evening.
My question is, sir, is there any role of, or is it effective to give a ripasudil? I mean,
ripasudil in which scenario?
Early corneal decompensation.
Only if there are some peripheral endothelial cells which are still viable, you can think about giving some ripasudil, which can help speed up the rate of migration of the peripheral endothelial cells to the center. The only disadvantage is if you don't remove that central DM with the unhealthy cells, maybe the recovery may be too long. So you have to think about something like a DUEC or a DSO where you create a space for the peripheral endothelial cells to come in. Other than that, you will end up with honeycomb epithelial appearance if you give. Most of the time, I've seen people with PBK who have been given either netasudil or netalo or the ripasudil, and they come back with a thick epithelium and the honeycomb kind of appearance of the epithelial hypertrophy. But yes, sometimes in Fuchs, some people have had success where the Fuchs dystrophy changes are only in the center, or it's very early Fuchs, they have seen regression and improvement. I don't routinely use it in my practice, but yes, you can try that. People are now looking at doing DSEK or DMEK and then giving ripasudil also in the post-operative period. It kind of, if the peripheral rim of 2 millimeter of endothelial cells, if they are healthy, they help cover up the gap between that and the donor. So your peripheral edema that you get, that can be minimized. So I think there are a lot of things that are happening, and no harm trying it, provided your patient tolerate it, because it's not a great medication. It stings and sometimes causes redness, and your patient will come back and say, I'm not happy with this drug.
Okay, sir. Thank you so much, sir, for taking my question.
Thank you. I think we have included all the possible questions who had been given to Dr. Fogla, and it's really our honor to have you, Dr. Fogla, and it's really nice that you spend another half an hour extra from the allocated time, and it was wonderful having you here, and it's really great to see an Indian ophthalmologist scaling heights across the world and teaching the West how to do the surgery right way, and you have shown the way.
That's the way it should be. If you share, you spread knowledge, and you reach out to more patients through all the people whom you teach. And thank you, Himanshu, for organizing this. And I had good fun. I am happy that I was able to answer the queries. And if people still have any queries, please reach out to me. I'll be happy to do that on a one-to-one basis as well.
Sure. I think at this platform, I would like to tell that anybody has any question. I really don't think any of our seniors and leaders in our field would ever say no to any one of us. So please feel free to reach out. Cornet is meant for that. It's meant for...
Just wanted to mention that as well. I don't see a lot of people using the Cornet. We have the US Keranet, which is so active. Every day there are so many queries posted on that, and a lot of people interact on it. We created a similar discussion group on Google called the Cornet. So all these questions that you're asking, if you were to put on Cornet, I'm sure many more people would respond to it, and we can have a fruitful discussion.
Yeah, and feel free to please reach out to anybody, and I really don't have any doubt that anybody would disappoint you. So please go ahead and ask your queries to whomever you wish. Like, if you think you're not able to reach out to us, any one of us, and we'll make sure that reaches to the correct person.
And I hope we are registered for the Keracon, and Mumbai, Himanshu and everybody else has put in an excellent program, and this time is going to be different. There are not too many didactic lectures, and we have a lot of clinical case presentations and discussion, and this should be good. So for those who have not yet registered, don't miss out the opportunity. And
please, guys, remember 3 days for yourself is nowhere more to ask from. You surely can put your own leaves, and whichever way, I really think it's worth it. So please come to Mumbai, and we'll have really great time.
We have a good international faculty as well.
Oh, yes. Thank you. And we wrap up this session. Again, thank you, Rajesh, for being here. And thank you, Bela, for being here. And thank you all for being on a Saturday night. And that to Diwali time. Wish you all a very happy Diwali. Thank you.
Wish you all a very happy Diwali. Thanks. Bye.